Greetings, Quest judging team. My name is Aziz Awad Al Karim. I'm one of the second year cardiology fellows, and I'm going to take you over my project, QI project, which is the DMC outside of the hospital cardiac arrest management algorithm. Um, to go over to lay the foundation for the presentation, I can so outside hospital cardiac arrest actually account for 350,000 annual adult deaths in the U.S. each year, and the biggest thing to know about those patients is that they have poor prognosis. Actually, 65% die in the hospital or before getting to the hospital, and only 35% we will be able to get return of spontaneous circulation to get them back with the resuscitation interventions we have. And again, on those admitted, only 10% of them will have a good neurological outcomes or they have a recovery after getting to the hospital. So the prognosis is very, very poor. And that's why there have been a huge focus on how to treat this subset of patients, which is different than people who get cardiac arrest inside the hospital, and to kind of know how to treat them. And as of recent, there have been until 5 years ago or until 2018, there were no randomized controlled trials on how to treat those patients. Um, and and as I mentioned prior, only two-thirds of them, the reason of death will be from neurological complications, and other 15% will die from multi-organ failure while in the hospital. Um, and as a result, they cause a very huge strain on hospital resources. And what makes the situation more is that there is a subset of patients with outside of the hospital cardiac arrest that the reason for arrest is due to acute cardiac events. And those people, if they can make it to the cath lab early, those people will have a good outcomes. Nevertheless, if you use this an umbrella on the other subset of patients who don't have cardiac events, what's going to happen is that you will delay uh, their fast tracking to the ICU and introduction for intervention that can lead to neuroprotection, which is targeted temperature management or resolving the main metabolic or medical reason that led to their cardiac arrest. So actually getting them to the cath lab could be harmful in their term of recovery. Um, so basically, as you know, Detroit Receiving Hospital, it's a county hospital, so receive many patients with outside hospital cardiac arrest. And due to an incident of one or two patients um, who went to the cath lab while that activation was inappropriate, we realized that we don't have a standardized evidence-based triaging protocol that help the communication between the ED and the cardiology department uh, in evaluating those patients in a structured way, especially as you know, as when they come to the ED, those decisions have to be made in few minutes from their arrival. So, what the basis of the literature that we have that we based our algorithm or triaging protocol on? Um, Basically, to kind of think about those patients outside hospital cardiac arrest, we divide them into people who have ST segment elevation in their post-recovery EKG and people with no ST segment elevation. Again, you can classify them on people who have PA arrest, which is pulseless electrical activity they had while they're arrested, versus people who had VT or VFib or shockable rhythm while they're resting. Again, people who become hemodynamically stable once they recover, and people who are not hemodynamically stable. Why this is important? Because we know from literature that people who have PARS and they don't have any ST segment elevation in their post-risk EKG, their chances of having an acute cardiac event is almost like 1%, very small. And this slide will help lay down the data we have from the literature and the probabilities of having an acute cardiac event. Um, so, and we know as of recent, because of guidelines, and this is a map of the um, trials, randomized control trials done since 2018, 2022, focusing on those different subsets of patients with no ST segment elevation, ST segment elevation that have been done, and it's actually impacted the most recent European guideline in 2023, and the SKY, which is Society of Interventional Cardiology in the US, in 2021. Uh, those, in a nutshell, those trials show that, hey, if you have ST segment elevation, you likely have an acute cardiac event. If you have VFib storm, you have an acute cardiac event. You will benefit from going to the cath lab. Any no ST segment elevation, actually randomize them to early versus late cath, showed no differences in outcome, and actually delaying the cath lab, taking to the cath lab, had a better neurological recovery, which is all in line with science we have so far. And this is a copy from the most recent um, European guidelines. Um, and then um, based on following this European guideline, there were more trials that we use to build up our algorithm, which is here. And I can quickly go over the algorithm, which is basically laying down all of this foundation I briefly went over, which is basically if you have outside hospital cardiac arrest, are you still getting VT, VFib storm? Then you should go to the cath lab. If you have recovery, then it's based on your EKG. Is your EKG 12 lead EKG showing ST signal elevation or ST equivalence? Call the interventional cardiologist, get the patient to the cath lab. If not, no ST signal elevation, then call the cardiologist, let them have evaluation, make sure you rule out the other major reasons like PE, people with metabolic problems. And if upon evaluation, there is a chance that this patient, because they're now awake and recovering, they have a chance of having acute cardiac event, can consider cath lab, but the focus should be into getting the patient immediately to the ICU to fix up their metabolic problems and consider delayed cath strategy. If the patient is still comatose, um, you call the and then based on the EKG, if there is a STEMI, get them to the cath lab or its equivalent, or if they're in cardiogenic shock. If not, then based on a wholesome evaluation of the patient, which include how long they have been down and witness arrest, what are the signs of like organ damage they have. Do they have very super high lactic acid? Do they have already into renal failure, liver failure? Um, and if that is present, uh, it can impact even the decision for people with STEMI, and mainly it will impact the people with no ST segment elevation, as trials showed there's no benefit for you getting to the cath lab. They actually benefit more from getting fast track to the ICU to be cooled and their metabolic dearrangement fixed, and then consider a delayed strategy. Um, so this slide going over the basis that we use for our building up our algorithm. And so how did we implement that? We basically, after that case that the patient did not need to be in the cath lab and had the poor outcomes, we did a M&M meeting. It was in the cardiology department. We presented the case, and then we introduced our algorithm. We discussed it with with our cardiology teams and cardiology department. Then we took um, that same presentation to our joint multidisciplinary meeting with the ED department and with ICU department to get their input. And after that, we distributed it electronically and in printed forms into the ED department, and we incorporated it within our CCU orientation, our ED orientation material, and then we did um, made sure we reintroduce it every 3 to 6 months in different conferences or lecture events that I personally presented. So as I mentioned, we continued enforcing it. And then when we tried to assess the evaluation. We basically went over all of the CAS labs and then CAS lab activation in the 9 months preceding and the 9 months after following the algorithm, and we found that 9 months before there were 5 cases that the CAS lab was activated inappropriately, and after that there were only 2 cases that were deemed inappropriate. Um, and which showed a real change in practice. Nevertheless, and which I think where the money is for this intervention is, which I can only have grasp of subjectively from the cardiologist, is how many CAS lab activation requests were before and after. And because we don't have that data, um, which is the instances when a patient like this came and the cardiologists were called and they were rejected on the spot. Um, and from having just subjective assessment and talking to the ED staff and talking to our cardiologists, they have been a huge change because this triage and algorithm made that assessment very structured um, in terms of decision making. And this is a bar graph showing the difference before and after. Uh, so what's the impact of this? Impact of this is in terms of costs. And as you know, the CAS lab activation is very intensive and costly intervention and averaging up to $40,000. Um, so that will have a huge financial cost cutting. Again, the biggest thing is strain on the CAS lab staff and personnel because, and it happened often. Our hospital is very busy, and during our calls, it happened almost once or twice a month that will be that our hands and the CAS lab staff will be tied into a case, and we'll have another patient who immediately need to go to the cath lab. So help picking up who go to the cath lab and benefit will help um, help cut down this cost waste and um, strain on the cath lab. Again, which is the biggest thing that this evidence-based algorithm will help is for the patient care, for the patient outcomes, which is, as we know from the literature we have, preventing further neurological damage is the key. And avoiding any intervention that can cause harm is no benefit, like exposing those patients to contrast, into bleeding complications, vascular complications, uh, prolonged sedation that can impact their neurological recovery is key in helping getting those patients have their best chances in some form of a neurological recovery at the time of discharge. And again, we're still there's still ongoing collection of the data to kind of over a more time, so as we can compare neurological outcomes before and after, which I think will help implement this project in a wider scale and being adopted in different hospital systems. And I have already submitted this project and was accepted at the Society of uh, Interventional Cardiology Sky, and I'm going to be presenting it personally in May 2025 in Washington D.C. Um, and once this data is collected, the neurological outcome data, because if we can tie it out to neurological outcomes, it can help impact and change practice in the even um, in the U.S. by getting this algorithm implemented in different hospital systems. Um, which is important, and that slides will talk about that. And then uh, to conclude my presentation, this is the algorithm we have. And again, if you have, I would thank you for your attention. And please, if you have any questions regarding the project, please feel free to reach out to me. Thank you so much for your attention.